services infrastructure. There you go. To create a shared services infrastructure in order to be able to leverage, one central repository for data for the whole state. So everyone shares and gets data from one central repository. That kind of goes into my next slide. For years past, long before there were HIEs, on the left, you can see that this is how you got data from one another. So if a patient came into a hospital or went to a clinic and they had an interaction with another healthcare provider a few weeks prior, you'd have to call, email, you would have to do something to try to get those records, those results. And you would have, hundreds of different organizations contacting hundreds of other organizations, and it kind of creates this spider web of connectivity. So on the right, you see now it's a shared services platform where basically everybody sends their data to MiHIN. We normalize that data, which we'll show you here in a second. And then we share that data out to the rest of the network, depending on whether or not you have an active relationship with that patient or they're a member of your organization. It's a very streamlined central repository kind of hub and spoke model, to use layman's terms. MiHIN today has over 4,500 unique entities that we work with in the state of Michigan, operating over 5,600 facilities. We are connected to 78 different EMRs, so we do get real-time data from 78 different EMRs, not just acute EMRs, but many, many EMRs from all kinds of different disciplines. As you can see there, we work with folks in the market segments of like hospitals, surgery centers, FQHCs, behavioral health, substance abuse, you name it. If it's a facility that's delivering healthcare services, we work with them. And the types of data that we get from all of our participants are any type of healthcare data that is available. If they submit it to us, we can take it between ADTs and CCDs, down to imaging reports, immunizations, public health reporting. We work with any and all kinds of data, and we can ingest any and all kinds of data. And so our goal is to take all of this data from all of these markets, and all of these EMRs. And sometimes people don't believe me on the EMRs, so I do like to show these are the 78 different EMRs that we actually work with. We take all this data from all of these EMRs, and what we do is we go through a normalization process. So when you get data on the front end, when you're working with software, that front end, for example, will have a date function where you have a drop-down calendar box and you just click on the date. And it's very simple on the front end, but on the back end, that data is stored. That data is stored. It could be a dozen different ways. So if we want to make a central repository where everyone can leverage the data and we can do very efficient things with the data, we need to take all of those dates that come in to our platform and normalize it so the output is just one specific date field. So for MiHIN, the top right, that is our date field. When you go into our product or see our services or raw data output, that's the date you're going to see. That's not necessarily the date format that we receive it in, but we normalize it to that. I'm just using very high level examples to to give you guys an idea of what we do. Another example, if you say, are you a tobacco user? Well, in the front, if a tobacco user, or if you ever use tobacco, it's a simple drop-down box with yes or no. But on the back end, it could say yes, it could say no, it could say Y, it could say N, it could say 0, 1, it could say A for yes and B for no. Again, that's us mapping all the data from all the different EMR systems, finding out what they call it, normalizing it so that we have one output to our clients and to the people that receive data from us. So you won't see it on the back end, but on the front end, when you see a report that says if they're a tobacco user, it'll say yes or it'll say no, or if they've ever used tobacco. So that's how we normalize the data. And then we take all the data from all of the facilities and all the EMRs, we normalize it and bring it into our central repository, and then we use that for HIPAA compliant services. So in HIPAA compliant services, there's TPO, treatment, payment, and operations. We'll get in here quickly on just the treatment things that we do, so exam rooms, emergency room utilizations, but also in the payment and operations, we know that there are hospitals whose billing departments actually use our our platform and our documentation in order to increase their case mix index scores or risk adjustment scores. So extra documentation, people are using it for payment purposes in order to code differently or code better. In operations, this is more for accountable care organizations and physician organizations that do care coordination and transitions of care and gaps in care, or they might have a tool that is working with their patient population that's a population health management tool that you load data into that gives you insights and analytics into the patient population where they can really hone in on specific areas. For example, which physician in my network has patients with the highest A1C levels? So you want to go and you want to tackle that population of high A1C patients that are concentrated under one specific physician. So the data is used for operational purposes as well. On the treatment side, we have, if you haven't seen this, and you might have seen it before or not, we put everything into one user interface. Very simply, this is why we exist. To have one solution where all the data goes in and it's the patient's longitudinal record. It's called My Gateway. And you go in and you can see if you have an active care relationship, you can see all of the history of that patient. So it's called longitudinal, obviously, because it goes from north to south, and the most recent interaction in any given segment is at the top, all the way to the oldest. So here you can see lab results, and it'll be their most recent lab at the top, and then their second most recent lab next, and so on and so forth. Same over here for encounters. You can see they went to the emergency room, they had an inpatient setting, and they went to an ambulatory setting. Again, longitudinal meaning most recent interaction at the top. So that's our front end application. It's used quite a bit in a variety of different ways. So in the clinical setting, they may use it to understand patient history, diagnosis, allergies, all the way down to streamlining their workflows. So they're no longer having to hunt down data like that original image that I showed you, where it was kind of the spider web. All the data they need to hunt down to make a better informed decision is right there at their fingertip in My Gateway. Emergency rooms use it quite a bit for better decision making, for past diagnoses, all the way down to lower utilizations, search and alert files for different reconciliation functionality. And one thing that we saw a study done, we didn't do this study in Michigan, but another HIE did it with another health system and saw that using the HIE's longitudinal record, one-stop shop for data access, reduce the length of stay by 7%. It's not double digits, but 7% is still pretty good. Larger hospital systems, we have seen that will use it for their registry departments. So tumor registry there's one hospital system in Michigan. Their tumor registry department uses My Gateway extensively. And then there's a lot of market segments that this data is obviously very necessary downstream for. So as we're getting the data in, hospice facility or hospice providers and rehabilitation centers, pharmacies even, that you don't typically think and consider a part of a healthcare network, but they do a lot of work to reduce the healthcare indicators for patients that are on high-risk medication and have comorbidities and things like that. So the application that we have, the My Gateway, is basically the culmination of all the data that we have in the network. So the more people that send us data, the more data that's in the platform. We operate it based on an active care relationship model. So if you have a relationship with that patient, you can see their data from other healthcare providers and vice versa. Other healthcare providers can't see patients' data that you have seen if they don't have an active care relationship. So the security of the patient and the protection of the patient's healthcare information is very, very important to us. And we've talked to a lot of HIEs in the country. We've been a part of a lot of meetings. In Michigan, we have a very, very sophisticated active care relationship module that a lot of HIEs in the country do not have. So we are really far ahead of the curve when it comes to protecting patients' healthcare information and making sure only those that are allowed to see it actually see it. So wanted to get into real quickly, there's incentive programs out there for different payers. Blue Cross has an incentive program. This is the incentive table that you see, high level. It's around data sharing. So when you're sharing data with MiHIN, Blue Cross incentivizes entities to do that. because it means better care coordination. The more data that you have, the more you can coordinate care. If that patient is consistently going to a clinic that is not connected to the network and sharing data to the network, when that patient goes to a hospital, that information is missing. So if we're not getting that data and a hospital is sending data to us, but that clinic is not, patient goes into your emergency room and they're lying there and you're trying to figure out when's their last lab? Are they anemic? Are they on any medications that I should know about? Are they at risk of anything? Those holes matter when it comes to the point of saving a patient's life in an emergency room. Vice versa, when a patient goes to the emergency room, their primary care doctor would like to know what happened in that emergency room, what led them to that, and get them in follow-up care. So Blue Cross has put together a great incentive program to make sure that data is shared from the hospital. So this particularly is health system focused,
Hey, Rick.
and this data, yeah, Brad.
Hey, sorry, just want to just not don't want to confuse anyone. The slide that's up on the screen right now is for our peer group 1 through 4, the larger hospitals. Um, so the peer group 5 hospitals have a different program,
Oh,
uh,
I got the wrong one. Sorry.
similar to this, but a couple of things on here don't apply. But it's enough to use as a backdrop to talk about P for
Yeah.
P.
Thank you, Brad. I didn't realize that I had the wrong one up there. That's my
No
fault.
problem.
So thanks for bringing that up. So there is a different incentive program, but the incentive program is still for one reason and one reason only: share data. When data is shared with the broader community, better decisions are made, better transitions of care happen, better gaps in care closure happens, better analytics and insights into patient trends so that you can intervene early on if a patient's health indicators are trending in the wrong way. The more data that you share, the more insights you have into the patient care and the more care coordination you can have between payers. We do have, and this is going to be based on the other conformance, but around conformance, really what we're looking for is the data that you send to MiHIN, is that data populated? Today, we don't measure the quality of the data. That is on a future path that we're going down to measure the quality of the data. Today, it's just, is the data present in the data that's sent to MiHIN? So we have conformance, and Blue Cross has, a guide that shows you the data that needs to be sent, and then the thresholds that you need for each of those data sets to reach. So, for example, in this one that you see here, the patient's last name, every single ADT that comes into MiHIN in this example, 95% of the time the last name has to have information in it. We're not verifying if it's correct and spelled correctly. We're just verifying if it's present. So that's an example of just, one conformance metric. We have modules inside of My Gateway, conformance modules that really dig into, based on what Blue Cross tells us, these are the things that we want you to measure. And when the data comes in, we measure it against those KPIs. And then we say, is this hospital in conformance? Is that hospital in conformance? Is this hospital missing any data that puts them below that threshold for that one unit? Pretty sophisticated capabilities for conformance. There's also not a lot of HIEs in the country that have this level of conformance that we do. This is kind of a large, take a big step back and see, of all the ADTs that would come in, what a true conformance would look like. When you're judging, is this measure above a 95% threshold? Is that measure above a 95% threshold? Those were just some examples. There's other thresholds where we know the data is more difficult to get. So there's a 75% threshold. Not everything is at 95%. So you guys are incentivized to send data to MiHIN and send data to the network, but also we want to make sure that there are data sharing from outside of the health systems. And there's, work that we do with physician organizations, skilled nursing facilities, et cetera, to try to encourage them and sometimes incentivize them when it's possible for them to share data. So from outside of health systems, we do have programs to try to get ADTs and CCDs and labs from outside of the organization. We're working with LabCorp and Quest Diagnostics to figure out how we can get that data from them. This is lab data that would happen completely independent of any hospital or any health system. This would be just a regular patient going to a regular primary care physician and them saying, I'm going to order some labs for you. Here, go to this address and have some lab work drawn. I've been to LabCorp before and had my blood drawn and had those results sent to my primary care physician. So there's all kinds of encouragement and incentives and within larger organizations. For example, the parent organizations that operate over top of all of the SNFs in the state of Michigan, all of the federally qualified health centers in the state of Michigan. We work with the 10 PIHPs that are over top of the 46 behavioral health clinics in the state of Michigan. So we really work with those organizations because we want to make sure that their data is getting into the network. The more data that gets into the network, the more transparency you have on any given patient, the better decisions everybody makes. So we want to make sure that data is flowing to the hospitals. It's just as important data flowing from the hospitals. So a lot of work that goes into this. Our team is focused on this day in and day out. We have, campaigns and programs and marketing. We work with the parent organizations, but then we also have a list of all of the facilities in each of those different segments. So we know all 40 of the FQHCs. We know all 46 of the behavioral health clinics. We know all 30 some or 40 some local health departments. We know the 548 skilled nursing facilities, and some of them belong to 29, parent companies that operate multiple skilled nursing facilities. We have all of that data. We know who they are. We know who's participating with us, and we know who's not. And our goal as a company is just to constantly be reaching out and trying to find what the impediments to data sharing are. And the key for us is breaking down those walls of what those impediments are. It might be they don't have the technical expertise. Like I want to share data with you. I just don't have the technical expertise. Well, maybe we can help you, or we can point you in the direction of someone that can help you. Maybe we can work together with your EMR company and see if we can get the data that way. A lot of EMR companies outside of acute EMR companies will charge, setup fees to set up a data feed to send to us. And they'll say, look, I can't afford the $5,000. So that's an impediment, a financial impediment to getting data to us. So how do we do that? Is there an incentive that if we did the math, we could say, okay, it'll cost $5,000 to set up this feed. We don't charge it, your EMR charges it, but you're missing $10,000 in incentives if you don't set up the feed. So if you can just set up the feed, those incentives are going to make you back your money in 6 months, and then you're in the positive. So our goal is to really identify as a company, as MiHIN, all of the healthcare facilities in the state of Michigan and who's participating in the network and who is not, and then group those that are not into groups of market segments that we can try to come up with a common way of figuring out what those true barriers are of getting their data to us in all of those different categories. So I know went through that pretty quick, about 20 minutes. I just wanted to stop here and say thank you. My contact information is here, rick.mcgraw@myhin.org. You feel free to contact me anytime. We have a great team here at MiHIN on our network growth team that reaches out, directly works with our clients. Once you're working with us, on a robust basis or even a basic basis. We have a great customer success team that takes care of our clients and makes sure that they're extremely happy and solving any kind of issues that you may have working with MiHIN. But I wanted to thank you for letting me speak and take the time with you and just kind of reiterate if you haven't heard before or if you're hearing for the first time, what MiHIN's goal is in the infrastructure in the state of Michigan is to be a steward of all the data, work with everybody on data that needs to be shared, work with MDHHS on public health data that they need, work with the payers to get the data in the network that they need to do the work that they need to do. We're all in this together. At the end of the day, all we care about is very simply when a patient goes into exam room, when a patient goes into emergency room, is the physician or the healthcare provider in that room at that time have access to every single piece of information they have at their fingertip to make the best possible decision for the outcome of that patient. That's the goal. And that's what we strive to work on every single day and work toward every single day. So I'll stop sharing and say, again, thank you for letting me take the time to speak with everyone. And if anyone's got any questions, feel free to fire away. Amanda, I didn't know if we were going to have any Q&A or if I
Yeah,
presenting and
yeah,
walking away. You let me know what's next.
yeah, absolutely. So there is a question in the chat that from Stephanie Elder. She says, "Is there different views in the MiHIN website? I am not seeing what you are seeing."
Different views in the website. You mean our myhin.org website? Oh, my
Uh,
gateway.
yeah, my gateway.
Yeah. Is there anyone
I can
else?
take this one, Rick.
There you
Uh,
are. It's
Hi,
Megan.
everyone. My
Yeah.
name is Megan Gibbs. I'm the Director of Customer Success. So, the module views that Rick had shared are representative of what we're calling our MITP My Gateway. So, last summer, we went through a pretty significant effort to migrate and essentially move from what we're calling Legacy My Gateway to MITP My Gateway. Stephanie, I'm wondering where you might see the difference is conformance. All of your conformance reporting for ADTs, labs, and discharge medication reconciliation are still housed within Legacy My Gateway, which is why the view looks a little bit different. We are in the process of essentially migrating conformance reporting to our MITP My Gateway instance. We're not quite there yet. So that might be why you see a different view on your side, especially if you're just using Legacy My Gateway to access conformance reporting versus the modules that Rick had shared on his screen are representative of MITP My Gateway, where you can view things like transitions of care or the longitudinal record viewer. So hopefully that helps. But if you do have access to MITP My Gateway, and the screen did look a little bit different, it also could be dependent on which modules you may or may not have access to. And so I do see your comment that you just put in. So, Stephanie, which organization are you with?
Stephanie, please feel free to come off of mute too.
Sorry. Okay. Um, I'm with Mackinac Straight Tel System.
Okay. So, what you can do is Molly Glass, who is one of our account managers that is assisting, and I know she's on the call today. What I'm going to do is a couple of things. Molly, if while I'm talking, if you don't mind putting your email address, Stephanie and Brian's, you can include mine as well in the chat. If you know who your contact manager, or if you know who your account manager is, you can contact them directly. If not, Molly would be happy to assist. So basically what we can do is have you meet with one of our account managers, walk through and kind of get a better understanding of how to use My Gateway, especially as it pertains to your data flows and what needs to be done in order to get you access. And then I would say too that if there's other individuals at Mackinac Straits that would be interested, bring them to the fun, right? We can set up accounts, we can do group sessions where we provide demonstrations, so everybody kind of gets the same information all at once. But more or less, yeah, connect with Molly and she will make sure to get you in touch with the right person and kind of get you and everything set up that you need to access My Gateway.
Perfect. Thank you.
Yeah, sure thing.
We have another message from, hold on, where are we at? Nicole Whitaker from Sheridan. She says, will the data sent to MiHIN be utilized to close gaps in care for BCBM SM clinical quality measures?
Take that one. This is Brad at Blue Cross. And I had to look at that question a couple times because we actually have a Nicole Whitaker on our clinical quality team. So I was like, why is Nicole asking that question? This is a different Nicole Whitaker. Yes, we do. Any clinical data that's sent to MiHIN, MiHIN kind of using their acres method, they weed out any messages that are relevant to our members at Blue Cross, and we get copies of those. So those are accessible to us for HEDIS gaps, things like that. So yeah, we do utilize that. We typically get a lot more from the physician side for the purpose of closing gaps, but we do have access to ADTs and CCDs and things like that for that purpose.
If I could just add to, hi, Nicole, this is Stephanie, your account manager. I know we've worked together a lot. You're not currently participating in that use case, but let's get together and talk about how you can, and I'll reach out to you in an email. How does that sound?
That sounds great. Thanks, Stephanie.
Yep.
Great. Brad, would you mind bringing up peer group fives for Blue Cross Blue Shield's P4P? I think you
Yeah,
should
let me do
have
that.
the access to share so that way we can show the group what the P4P is.
Yeah, I'll do a real quick run through. We don't need to dig in unless there's a lot of questions, but I'll just show the program guide for the Peer Group 5 Hospital P4P program for the current program year, which runs April 1 of 26 through March 31 of 27. Really, so the P4P program, at its core, what it is, what's at stake is a 2% increase in the reimbursement from Blue Cross. And the way we do that is we basically ask you to do some things. If you do those things, we increase your reimbursement from us by 2%. The things we ask you to do boil down to these two things. It's much more concise than the peer group 1 through 4 P4P program. There's 5 different domains of things, and only one of them is health information exchange related, whereas this one is you have a culture of patient safety segment where there's a CEO attestation that is completed every year. For this program year, it's due April 30th of 27. And then the other 100% of the score that determines what portion of that 2% increase in reimbursement you get is based on the HIE portion. So that's really the long and short of what the HI or the P4P program is for Peer Group 5 hospitals. And this is how it breaks down. You've got 3 measures. Send your ADTs, meet certain conformance guidelines on the data within those ADTs on certain fields. Measure 2 is send your CCDs. Those are those also known as MedRecs. Some people call them medication reconciliation, post-discharge, blah, blah, blah. But those CCD documents are all HL7 documents here, ADTs, CCDs, and the labs. So those lab ORUs is the third measure. There is no conformance applied to the data in measures 2 and 3, just on measure 1. Things may be changing with this soon. We'll obviously socialize that and roll it out and let you know what we're thinking before we do anything. But this is the long and short of it right now. And the points are broken out, as you can see here, 4, 3, and 3. And this is what the conformance looks like on the ADTs. It's populate these fields with accurate, complete data 75% of the time. We look at all of these fields. We give you an overall score. If you're 75% or better on that overall score, you get the points for measure 1. And if you send your CCDs, you get the points for measure 2. And you send your labs, you get the points for that. That's really that's all there is in this program. And what Rick did is give you great background on why this program exists. This program exists to encourage that sharing of data with MiHIN and all of the great things that they have and the capabilities they have with that data and the ways they can share it out to the end users so that primary care physicians have knowledge of what's going on with their patients. It's all super important, and that's why we have this program in place, and we offer that opportunity to increase your reimbursement. I'm happy to field any questions you might have about that.
Thanks for sharing that, Brad. Deb Law wants to know veteran status, yes, no, is not incorporated into this, correct?
That is correct. That is not one of the fields we look at in the measure for ADTs. And I do not have a way to stop sharing, so I don't know. I don't know how to. If somebody can like control that, I don't know.
Let me see if I can stop sharing your screen for you. There we go.
Okay, thanks. Sorry, there's no button to unshare. Weird.
That's okay. Are there any other questions that you may have for MiHIN or Brad? No. Okay. Well, today's 1 hour is going to be a little bit short, and that's okay. So we learned a lot, and we appreciate everybody being here online. Let me see. I want to just check. Nope, no other questions. Thanks again for everyone for joining and taking some time out of your day to learn a little bit more about MiHIN. We will be reaching out to you soon with a survey to rate this educational webinar and to see what other resources or education that you might need as it relates to the Blue Cross Blue Shield P4P or to MiHIN directly. Oh, Katie, I saw you came on.
Yeah, sorry, I was just going to say that we'll also update the slides with the table that Brad shared, and we will send those slides out for the group as well, so you all can have those to look back on.
Appreciate it. Thank you, Katie. All right. Well, thanks everyone for joining. Have a fantastic afternoon.
Thanks, everyone.
So much.
Thank
Thank
you.
you.